Dr. Rubal, you may begin.
Good evening, everyone. My name is Dr. Jorge Rivera. I'm the Executive Director and CMO of the Laguna Beach Community Clinic. I want to welcome everyone who's joining us this evening for Laguna Beach Community Clinic's 5th Annual Community Health Symposium. I think this year's topic, although unfortunately kind of self-selected itself, I think it's a particularly relevant one given the current pandemic that our nation and the county is currently undergoing. I think each one of us in some shape or form have been affected by the virus, and this includes the clinic as well as all my colleagues at all the safety net clinics in the county, whom from the very beginning have been involved in assisting our patients and the community deal with the virus. The clinic in particular has been able to keep its doors open and continue to provide services, including pivoting towards telemedicine in order to continue to provide those services. We've been fortunate to be involved in early testing as well as vaccination, as well as community education in various forms, including the symposium. The goal of the symposium has always been to provide evidence-based information so then we can have a respectful discussion afterwards. So today we've been fortunate to have gathered a group of community health experts to share information on the virus and the pandemic. I want to quickly introduce them, but I also want to thank them all for being here today, as well as for being on the front lines of this, whether at the hospital and helping taking care of patients, helping navigate the county's response to the pandemic, dealing with those communities in the county that are most affected, as well as mental health issues that have exploded as a result of the virus. Our keynote speaker today will be Dr. Gohil. Dr. Gohil is an assistant professor in the Division of Infectious Diseases. She's also the Associate Medical Director for Epidemiology and Infectious Prevention at UCI Health. Dr. Gohil's presentation will be followed by short presentations by our panelists, and then we'll have a question and answer session for you to participate in. Our panel, I'm very proud to say, is composed of Dr. Clayton Chow, who is the Agency Director and the County Health Officer for the County of Orange. We have Dr. Jose Mayorga, who is the Executive Director as well as the Executive Medical Director for UCI Family Health Centers, which are also federally qualified health centers. He is also an Assistant Clinical Professor in the Department of Family Medicine. And lastly, we have Mr. Marshall McCreath, who is the Chief Executive Officer for MindOC. I know we have a limited amount of time, but we have a wealth of knowledge that we want to share with you. So I will step aside and let Dr. Gohil dive right into this. So if you could please help me welcome Dr. Gohil. Dr. Gohil?
Oh, can you hear me okay?
Yes, we can.
Oh, my apologies. Okay, great. Great to be here, everybody. We have about 20 minutes, and I thought, boy, there's so many things that we can talk about for the COVID-19 pandemic. I'm going to focus ourselves on where are we now to give us some context, and then talk about what I think is one of the most important steps to take to end our pandemic. So next slide. Go ahead and advance to the next slide. Okay, here we are with our cases worldwide, over 100 million cases globally, truly on another level with regard to respiratory diseases, at least in many of our lifetimes. Next slide. And here are the cases in the United States. What we want, I think many of us have seen graphs like this. This is from the CDC, and this is a daily trend in the number of COVID cases in the U.S. that we have reported. Of course, those that go unreported are not captured here. But what I want people to notice here is we've had all these baby waves, the waves in the spring of 2020, then in the summer of 2020, a little bit larger. And then as everybody in our field in infectious disease had predicted or known, we would have a large surge in the fall, in the winter. This is totally predictable. Usually in our world, we say anywhere from 2 to 10 times the previous preview virus peaks. That's how much you expect in a fall surge for a respiratory virus. And boy, that has proven itself to be quite true in this case. Next slide. And here are the state trends for just a selected few, 6 states, and I chose carefully here. We have California in green. Look at us on the top over there. Interesting, New York, very congested type of place, and of course the overwhelming COVID that was seen there earlier in March of 2020. They saw a peak where all of us were quiet. Clearly that system learned a lot. The community learned a lot, and so they stayed flat for quite some time. And then, of course, as the cold and flu season came upon them, they also peaked, but nowhere near where we are in green, many fold up higher than New York and many of the other states, including the West Coast states. Next slide. This is a chart of the U.S. daily deaths, so how many people are dying every day of coronavirus. And thankfully, it's not as large of an absolute peak as the overall incidence, which is also predicted. But look at that, quite sobering to see that the deaths continue to climb. Next slide. And here is our local Orange County hospital. And here I have to give a huge kudos to Clayton Chow, who's going to join us a little bit later. But the Orange County response, the Orange County ability to stay on top of the numbers has been just absolutely nothing shy of incredible. Information is everything. And I'll say that I go to this website maybe every day. So very, very thankful for the resources being provided to our community. But here is a nice graphic of exactly what's happened locally in our communities. And we do see this U-turn in our peak. Many of us are feeling like, okay, well, maybe we've passed the worst, just like clockwork. After Thanksgiving and the holidays, boom, 2 weeks later, as we all expected, people did end up congregating and gathering and spreading, allowing more pathways for the virus to spread. And of course, we felt it, didn't we? Now we look around, we think, is this over yet? Well, again, a reminder that we're manyfold up higher than we used to be in the summertime, which was a pretty big peak itself, actually. So this is all hospitalizations, not even daily incidents, but just a humbling, even though I think many of us are really tired of this pandemic, we want this to end. I just want to put it out there that a lot of the stay-at-home measures or the social distancing and the masking and all the things we do to prevent the spread are just critically important. This is a particularly dangerous time to walk backwards on some things. Just keep your mask on and be careful out there. While the cases are going down, we're still manyfold higher than we used to be. Next slide. All right, so that brings me to this next topic. I present you with all of this data and sort of a doom and gloom kind of picture. Wait, we're not out of the woods yet. Well, what are we going to do about this, and how can we end this pandemic? And I will say vaccination, vaccination, vaccination. Next slide. So dedicated my talk to the key points we want to make about vaccination, hoping that this information helps you think hard about going ahead when eligible, when we have enough vaccine supply, to please go for it. What's the data? What's the data? How good are the COVID mRNA vaccines? Pfizer and Moderna, as you all know, top two that have made an mRNA vaccine, have run large-scale trials, 44,000 in one case, 30,000 in another case. And this is a trial of a vaccine called an mRNA, messenger RNA vaccine. And what that is different from our other types of vaccines that we have available to this date. In the past, what we've done is taken viruses and killed them or made them extra weak, and then injected that into humans, and your immune system is able to learn what the virus looks like and make antibodies against it and kill it if the real thing comes along. So it's basically teaching your immune system, hey, get ready, make these antibodies. If you see the real thing, attack it. Well, what we've done here, instead of a weakened virus or a dead virus, what we've done is create a messenger RNA, which is basically like an instruction set that your cells will take in and learn how to make the spike protein. You've all seen that picture of the coronavirus with little spikes hanging out of it. It will teach your immune system to make an antibody against those spikes so that it can neutralize the virus, neutralize meaning coat it, and then kill it when or if you are confronted with the real COVID. So it would not be a vaccine with virus in it. It does not multiply. It doesn't mix with your genes. There's a lot of information out there on the media or other places where people talk about these possibility of something happening to your genes. That is not possible. The beauty here is that this is a messenger RNA. Once it gets used, that instruction set, once it gets used, it disappears, it disintegrates. And it's one of the reasons, actually, why this vaccine is hard to roll out, because you need ultra cold storage, because the messenger RNA is so fragile that once it enters, once it's read once, it actually disintegrates. So that's really, really should be really encouraging for a lot of people. And then again, as I would just want to underscore, because I think other people have this concern, the idea that it cannot give you coronavirus. This vaccine can't give you COVID. And the final thing I'll say on this slide is that the efficacy has been tremendous, 94 to 95% efficacy. And the regular influenza virus that we have annually ranges anywhere from 25 to 60% in efficacy, and it still does a whole world of good. So imagine at 94, 95% efficacy, we're pretty excited in our world. Next slide. All right, so here are two trials, and wow, so what you're looking at here are the number of accrued COVID-19 cases and placebo, in other words, the arm of the trial that in which the humans got no COVID-19 vaccine, versus the intervention arm, which is the COVID-19 vaccination arm. So on the left-hand side is Pfizer, and you can see in the red, those are all people who didn't get the vaccine, and in the blue, all the people who did get the vaccine. And amazing departure at around 14 days, boom, the vaccination arm stops getting COVID at a very, very significant difference. Same thing with Moderna, just we flip the colors there. Blue is the placebo there, and the red here is the people who got vaccines, and very, very flat after they got the vaccine. Next slide. So is the vaccine good across race and age? And people have been asking questions about that, and it looks like, in terms of the representation for age, both vaccine trials included quite a wide representation, and you can see the efficacy numbers are pretty high in both Pfizer and Moderna when you look at it splayed by age. Note the race and ethnicity. Looks like they're both equal if you look at Pfizer and Moderna. It doesn't matter which of them you get for the most part. There was a little bit higher enrollment of the Hispanic and Latinx group in Pfizer, but very small percentage-wise. So we consider both vaccines quite equal, both in their distribution of who got studied and who it is efficacious in. Next slide. So in terms of the 1 dose versus 2 doses, people have been asking, oh, what if I just get 1 dose? What if I can just, get away with not doing the whole series? We strongly recommend that you do both doses. Both trials are showing the same thing, that before dose 2, you get less protection. After dose 2 is really, if you want the benefit at that 95% rate, you've got to get both of the doses, and you got to get it on time. Next slide. Some people ask and wonder how much vaccine is going to stop this epidemic. The experts are estimating anywhere around 70% or greater percentage of the population should be immunized in order to have protection, herd protection from COVID. Natural immunity, it's worth noting here that people who get natural disease really should get vaccinated as well, because the immunity, the antibodies you may generate if you become sick with COVID may or may not be fully protective, is one of the things that we are learning. We do see cases of reinfection. So the recommendation is to still go ahead and vaccinate previous COVID positive individuals. So here, what you see in the chart are just a comparison of the kinds of other viruses that are out there and how much vaccine coverage is needed. And COVID, as you would expect, 70%. Influenza would be the next approximate kind of virus. And there we hope to achieve 30 to 75% for a variety of reasons, but 70% is absolutely what we need to end this pandemic. Next slide. Herd immunity threshold by pathogen. Now, this one, I think we had just gone by, but go ahead and skip to the next slide. I think that's a duplicate. Okay, will the vaccine make me sick? Yes, we do see a fair amount of side effects, but that doesn't mean you're actually sick with COVID. Again, this is not a live vaccine. It is not an infectious pathogen that is being put into somebody and making you sick. When you get sick from the COVID vaccine, in terms of side effects, they can be muscle aches, fever, fatigue, headache, chills, joint pain, and nausea for the first day to 3 days. But those are all related to the chemicals released by your body in response to the vaccine, and it's revving up to make those antibodies that are going to protect you. So that is the reason why you get any side effects from the vaccine, and you shouldn't be feeling too worried about them, and you'd use Tylenol or any over-the-counter anti-fever reducing medicine. Next slide. Here's another big question that people come in with: are my allergies a risk for the vaccine? There's been a lot in the media, rightfully and understandably so, about allergies, and we are still learning a lot about the vaccine and any type of allergies. But one thing is very, very clear. All of our vaccines have risk for allergies, and that has been true since the beginning of vaccines. And if you look at the rate of allergic responses to other vaccines, this vaccine does not appear to be at any greater percentage risk for allergic reactions than those others. Although, again, the caveat is that the data is emerging, but I'll leave you with this idea that, we've had allergic responses or anaphylaxis in several rare cases, and that's amongst 23, now probably 24 million mRNA vaccine distributed nationally. So if, and we haven't heard about true deaths associated with allergy, although there have been 2 reports in the media about this. We are still pending investigation, but 2 out of 23 million is way less than, say, other vaccines, MMR, for example, and varicella, which have ranged from 1 in 1 million to 1 in 4 million. So we are way lower than that. And then I want to clear up, some people want to know, well, what should I do? What if I have severe allergies, seasonal allergies? And, CDC made a very responsible statement saying, hey, if you have any history of any type of allergy in general to foods, or have to carry an EpiPen around, bring your EpiPen with you, and stay in observation for 30 minutes, which most providers will allow for some process by which you can do that if you have that kind of a history. So that with that, I will tell you at UCI, we've done many, many vaccines, over 8,000 to 10,000, and there have not been observed any issues, including amongst those healthcare workers who had allergies. We observed them. We've never had to use an EpiPen, knock on wood, yet. Next slide. Pregnancy and immunocompromise. There's an active dialogue about this in the media, with the World Health Organization just this morning making a statement that that these vaccines should be held from pregnant or breastfeeding women at this time. The CDC has recommended that that people who are pregnant and breastfeeding are people who there's no inherent reason why this vaccine should be withheld from that group. It's just that the studies did not include this very important population. And because the studies didn't include this population, we don't know about the data. We don't have the data. And the real concern would be whether or not you would mount a good response, because pregnancy is a time of relative immunosuppression. And so when your immune system's down a little bit, you may not make the right antibodies. And that was the thinking behind some type of caution. But however, that said, the society, the American College of OB/GYN, and a couple other societies nationally have come out with really important statements saying that actually lack of data doesn't mean that the vaccine itself is inherently bad for pregnant and breastfeeding women. So those with real risk, suppose that's risk because they're essential workers, suppose that's risk because they are going to get exposed to COVID, they should have a direct discussion with their physicians. And that is CDC recommended, that on a case-by-case basis, you may consider vaccination. I will tell you at UC Irvine, we have extended vaccination to pregnant or breastfeeding women if they desire it. We don't say that they can't have it, and it's a personal choice. Next slide. All right, can we stop masking? I will say here, okay, say you've got the vaccine. Our healthcare workers at UC Irvine, for example, we're doing really well with vaccinating all of our physicians and our nurses. So can they just, be in the hospital without a mask? Absolutely not yet. We still are waiting for data in terms of the duration of protection that the vaccine can give. But more importantly, we are still in a pandemic. We are still in a place where there's 4 to 5-fold higher COVID out there. And there is the possibility that you could be that 4 or 5% in which the vaccine didn't work. It's an unlikely thing, but also you're part of a community, and we have to minimize any risk that that COVID could be transferred. So it is important to everybody keep masking, keep doing the social distancing, and keep hand washing. Next slide. All right, I think I mentioned this before. Can I take one dose? Can I take a late second dose? And what's the wiggle room? And what if I didn't get it perfectly on time? The trials were done very specifically, and they talk about 21 days for Pfizer and 28 days for Moderna. And it is true that most vaccines have a period of time when you can, it's like a grace period. You don't have to be exactly 28 days or oh my gosh, this thing won't work. That's not the way the human body works or vaccines work. And so we believe that the wiggle room is probably sitting at around 1 to 2 months. But we should all try really hard to be relatively on time with getting our vaccines, ideally at 21 days or 28 days, depending on which vaccine you get, but wouldn't stress out if you wouldn't hold back a vaccine. If you show up at 6 weeks from the other time, we would still go ahead and immunize you at UCI, and that is according to our CDC guidelines as well. Next slide. All right, what if we don't reach the 70 to 85% vaccinated? Well, there's a sizable amount of virus circulating in our population, and we anticipate fully. I mean, I couldn't stress enough how important it is how quickly we vaccinate. every day that goes by, the virus is has the potential to not only mutate, but also just continue spreading. And the faster we get people immunized, the more likely it is that we get on top of this thing before it really becomes a strain that hangs out with us for a while. I think that many of us do feel that if there is insufficient vaccination early on, as early as we can do it, that next winter we do expect COVID to resurface. If you take the example of H1N1, which was the swine flu, if you all remember, back in 2009, well, once it got a foothold in our communities, it was hanging out until it was a dominant flu strain until 2016. So we don't want that to happen with COVID. Next slide. All right, in the news, the COVID-19 variants. Does the vaccine work? Am I protected if I get my vaccine? Well, the truth is that the virus is mutating all the time, locally, regionally, everywhere. We can see, when you do genomic analysis, you can see that the virus is mutating. That is not a surprise. That is exactly what viruses do. They're little engines to actually mutate. In fact, influenza, one of the fastest mutators ever. So that's not a surprise to anybody who's an infectious disease physician. The real question is the mutation significantly different, such that it changes the whole face of the virus and looks different to your immune system, such that the vaccine that you took is not going to work anymore. It doesn't recognize the face of the virus. So that is the real question here. And we're lucky. So far, the variants from the United Kingdom clearly show that our vaccine is likely to be very effective against the UK variant, the South African variant less so, but still reasonably thought to be potentially reasonably protective. We won't know until we actually see what the strain does in a population that's vaccinated, so that data is not available. But by all measures that we can see, the vaccine serum, so if you take a vaccinated person, take their serum out and put it on the South African virus, it does successfully neutralize it. So that's good news. All right. Oh, and the other thing to mention, of course, is that the mRNA vaccines, one of the great reasons why this is a good strategy as opposed to previous vaccines is that it can be quickly modified, quicker than other technologies for vaccination manufacturing. This mRNA vaccine can get quickly modified and get a new variant vaccine out there manufactured much quicker than previous methods. Next slide. All right, and does the vaccine work in terms of your overall, how do you stop the variant and how do you actually manage to get on top of these things? It really does show that that when you get on top of an amplifying COVID-19 season, this is a seasonal virus at the end of the day. And if you were to maximize vaccination during this time, that's how we would stop our variants, actually, is through vaccination, because we would reduce the amount of circulating virus, and it would reduce the circulating virus if we kept our masks on and did our hand hygiene and all the rest. That's how we're going to get on top. Next slide. Okay, this has been in the news, so I thought it would be worthwhile to bring forward this idea that asymptomatic individuals who had been vaccinated, they could still shed to other people. The answer to that, it's not clear how this actually got circulated out there. To an infectious disease physician and many others in my role across the nation, this is not a thing. This doesn't happen. There's no carrier state for cold viruses, and that includes COVID-19. If you happen to be so unlucky that you got a secretion, you were vaccinated and you got somebody else's secretion on you, you failed to wash your hands, you took some actively wet secretion and transferred it to somebody else, could you transfer it? Yes, but not because you got you acquired the virus and was asymptomatically sick from it or something like that. That is not known to happen in any other virus. The other caveat is important to mention is that if you are vaccinated, it is possible that you could get a lot of virus introduced to you. Say you have a child who was sick and you introduce yourself because you're very short region, in your nose or mouth, and you got a bunch of virus on you. Could you override your immunity protection that you have through your vaccine? Yeah, that's possible. Then could you spread? Yeah, that's possible. Very low likelihood, but that wouldn't necessarily be a dominant mode of spread. Next slide. Here are COVID cases. I'm sharing something from UC Irvine. I just want to share it because it's important about the asymptomatic disease question. After vaccination, the percentage of healthcare workers who were positive and truly asymptomatic dropped dramatically to almost nothing. So I just want to put that out there. The vaccine has turned around our hospital completely, and the number of healthcare workers that are positive in general, let alone this whole idea of asymptomatic, because we do asymptomatic screening, and that number has fallen dramatically. Next slide. Okay, those are the statistics. After vaccine, 12% cases asymptomatic. If you call them up, even less, actually more like 3%. Next slide. Okay, the other thing I wanted to mention, to close up with, is this idea of the population impact. Is just this reminder, I've been saying it all along, but this idea that we're at a plateau at this point, maybe an early U-turn. We still, at the time that I was writing this slide deck, it was still 0 ICU beds, even though today we have opened up maybe 10 to 15% ICU beds in Orange County. But we really do need to be really responsive to the severity of the peak that you see in front of you, several-fold higher. Masking is still in order, and please have caution with large gatherings, and the population has barely just begun to become vaccinated, so just continue your caution. We would hate to go backwards. Go ahead, next slide. All right, I think I'm realizing that I'm running pretty much at the top of the hour, Jorge. Maybe I'll speed through these influenza slides really quick just to remind people that the Orange County influenza seasons, this is what things look like in previous years, 2013 to 2018. We had a lot of flu circulating. Next slide. And this is 2019, 2020. And you look around for a curve for 2020, and because we were all, dealing with COVID, we don't even have case numbers I can share with you here. But guess what? This year, next slide, influenza cases at UC Irvine Medical Center, 0. We have performed over 7,000 tests for suspected influenza, gotten 0 influenza in our hospital. County-wide, that's a good number to know. Dr. Chow will give you the latest, I'm sure, but that last time I looked earlier this week was only 130 or some very small number. So the light, if you can call it a silver lining, the masking, the social distancing has worked to really mitigate influenza. This year we have basically very little influenza circulating at this time. Next slide. Just want to share with you a picture of the first batch of vaccines arriving to us from Orange County. It's just been a tremendous county to work with. They called us and we received it, and we came and greeted the box of vaccines as though it was like precious gold. And we had a security guard and a whole team from pharmacy and all the way up and down the chain, taking in this historic moment. First mRNA vaccine and one to end this pandemic. And on that note, I will end.
Thank you, Dr. Gohill. Fantastic presentation. Lots of good information for hopefully us to take back to our friends and family and colleagues, and again, continue the discussion. I would like to quickly invite Dr. Clayton Chow, again, who is the county medical director, maybe speak for a couple minutes in terms of the county perspective and anything that you think you would like to share with our audience.
Thank you, Dr. Ruban. Good evening, everyone. That was a wonderful presentation, Dr. Gahir. Thank you so much. Just want to quickly make a few points, and then we can have the discussions. Don't know if you all aware, but this last Monday marked our 1-year anniversary of the very first case of COVID-19 here in Orange County. Um, we, the entire community, all of you, have been with this pandemic now for close to a year. And I know there's a lot of sacrifices for the healthcare provider, risking their life to take care of our community, for our children, and staying home. And most are not, have not been able to come back to school for in-person instructions, especially in area that we identify at hotspots in the community, area where we have high positivity rate and infections cases. We know that there are businesses, especially small businesses, that had to close forever, and that affect the many of our individual who are trying to build their legacy for the next generation. And so the effect of the pandemic is not just the physical, but clearly the emotional aspect of it, as well as the financial, economic aspect of it. We officially, this past Monday, um, has been able to leave the statewide lockdown for the entire state based on the projected 4-week forward ICU bed capacity. And for those of you who are interested in that calculation, you can view it on the state website. As Dr. Gahir showed you a slide where the number of our hospitalization in the non-ICU bed has dropped dramatically this last week. And to a certain extent, the number of the ICU bed also dropped as well, but not as fast as I would like to see. I'm nervous for the next week to see what would happen. But you're right. Even with the first dose of vaccine, we have seen some story from different business sector talking about the dramatic drop in the percentage of their staff that get infected with the virus. Um, in Orange County, currently, there's over 100 and close to 110,000 people at least have gotten their first dose, and close to 40,000 have gotten their second dose. Um, we know that the demand for vaccine is really, really high in California, and particularly in Orange County. Um, that is good news. But the not so good news is it created frustrations in the community just because we don't have enough vaccine to go around. Currently, in the state as well as in Orange County, people who are healthcare worker part of phase 1A are eligible for the vaccine. And then we've added recently within the last week and a half, individuals who are over the age of 65 who are also eligible for vaccine. That total number here in Orange County is somewhere between 660,000 people, perhaps more. But so far, the allocation to Orange County has been hovering around 220,000. So as you could see, there are a significant number of folks who are eligible still are not able to get the vaccine just because the supply continued to be small. With the promise of President Biden to bring 100 million doses to America in the next 100 days, we are hopeful that the vaccine will come. Um, I'm not going to get into all of the science of the vaccine. Dr. Gahir did a wonderful job on it, and she's right. The goal in Orange County on New Year's Eve of this year, we activated Operation Independence, and that is our goal to achieve majority of folks who want the vaccine to have the vaccine to achieve herd immunity by July 4th. We are hopeful with the new direction, with the new promise of more vaccine. We are hopeful that we will get there. I want to share with you that is continue to sadden me when we see people who are still requiring um, severe, at the highest level of care, as well as people continue to die. And so in Orange County, when you look at those who die, 75% plus of folks who die over the age of 65. And when you look at the folks who are in the hospital, especially ICU bed, about 72 to 73% of those who require that level of care are individual the age of 61 or above. And so what I'm pleading to the community is allow our senior who are high risk to have the opportunity to get the vaccine, and be patient. The vaccine will come. Keeping my finger crossed that it will come fast so that we will have the ability to vaccinate the entire community to reach Independent Day. So with that, I will stop for now. Thank you.
Thank you, Dr. Chow, for sharing that information, especially from a accounting perspective of what will be coming up in the next couple of weeks. Next, we'll have Dr. Jose Mayorga speak specifically in terms of some of the communities that have been hardest hit, especially when we're looking at, we keep hearing vaccination, vaccination, vaccination. Who we will be potentially concentrating on. So I will let Dr. Jose Mayorga speak now.
Thank you, Dr. Rubat. Thank you very much, everyone. Good evening. It's a pleasure to be on the panel with such great guests. So we're going to go through something that's really near and dear to my heart, and that is the impact this infection, this pandemic has had specifically on the Latino community. Next slide. So a little bit about the organization or the clinics I oversee. They're in the heart of what Dr. Chow mentioned as the hot zones. The two clinics I oversee are in the city of Anaheim and Santa Ana. We are the oldest FQHC in the Orange County space. Our oldest clinic in Anaheim has been serving patients since 1977. Combined, these two sites take care of 24,000 patients, and we see everyone from 0 to 99. We're very proud to be able to do that for the community. And when this pandemic hit, it was absolutely imperative that we were prepared to address their needs, just like all the other community health centers, just like Laguna Beach Community Clinic, really addressed the pandemic. Next slide. So what happened? What happened when this pandemic first started? Well, let's recall, you may have heard early on, people who were getting diagnosed were folks that were traveling abroad. They were traveling abroad and they got tested. They had access to healthcare. They had the financial means to get tested. And for a long time, we kept hearing, we need more testing. We need more testing. Well, yes, absolutely, we needed more testing because we knew that there was a high likelihood that this virus was circulating a lot sooner than it was originally projected to be. Next slide. So really, what has happened? So this is national data. What this slide is showing you is over the past several months, the coronavirus pandemic has exposed the health inequities that have disproportionately impacted minority communities. And I highlighted the box specifically that we're talking about the community made up of Latinos. So if you look at it very closely, cases are a lot higher in Latinos. They're more likely, 4 times likely to be hospitalized. And the unfortunate thing, they're 3 times likely to die compared to their counterparts. Next slide. Nationally, this is another really big thing. This is data that Johns Hopkins continues to provide every day. But the top 10 counties of COVID cases, five of them are here in California, specifically the 5 Southern California counties. So yes, unfortunately, we have that notoriety that we are really, really the hotbed of COVID. Next slide. So what about California specifically? Well, let's talk about the disproportionate amount of cases impacting the communities that we tend to serve in the FQHC space here in Orange County. Next slide. So we know that 39% of all the people that live in California are Latinos. But the reality is, next slide, the reality is that 55% of all the COVID cases are Latinos. And unfortunately, 47% of its deaths are Latinos in nature. Next slide. So when you look at this particular table, what is it really telling you? Unfortunately, what it's telling you is the Latino community is dying at a higher rate, almost a 21% higher rate per 100,000 compared to other ethnic minority groups and other predominant groups in the entire state. This is extremely, extremely impactful. So, but what about Orange County? Why don't we talk about Orange County, because this is where we're at. Next slide. So in Orange County, Latinos make up about 35% of the population, but yet they make up 44% of all cases. Next slide. And furthermore, the sad part is they make up about 39% of all deaths. So where is this all happening? Well, next slide. I shared with you that where this is all happening are in the two areas where my two clinics are at. 20% of the Orange County population lives in these two cities. And it should not be any surprise to you that these two cities are predominantly Latino in nature. And unfortunately, these are the folks that are dramatically getting impacted. And when we talk about vaccination, you bet we're really, really concerned. Dr. Chow is very concerned. Dr. Gohel and all the other experts in this county are really, really concerned about these communities. Next slide. But why? Why are they getting sick? So this is a really important point. They're getting sick because of the socioeconomic disadvantages that they've been facing for decades. This is not something that just happened overnight. These particular cities that I'm highlighting are densely populated. They are made up of essential workers, and the living constraints that they are in really make it a difficult time to be able to care for themselves if and when they get sick. Think about this for a moment. People who are living in these homes are multi-generational. They're likely renting an apartment or living in a small home, likely to have only one bathroom. And I know this because these are the patients I see. This is what they tell me. The minute I diagnose their grandmother, the biggest concern they have is grandpa gonna be okay? Or am I now gonna get my daughter who's pregnant sick? So these are really, really important things to understand. Unfortunately, as you look at some of the data, you know, a lot of these people are living in federal poverty levels way higher than the other parts of the county. So what do we know about that? We know that living in poverty has a direct correlation with you not having good access to healthcare. And so this is also another reason why it's such a big deal. Next slide. So really, we have heard lots about the medical conditions that put you at increased risk for complications to COVID-19, but I'm going to tell you tonight that really the biggest risk is your social determinants of health. Your biggest risk is where you live, where you learn, where you work and play. Those absolutely are higher risks for you to be impacted by COVID-19. Unfortunately, this directly is linked between poor social conditions and environments where people are living in. And this has been escalated and magnified with the situation we're in. Next slide. So what are the things that are the Latinos are being impacted? Well, let's talk about this for a second. We are essential workers. This community are essential workers. Why? The U.S. Bureau of Labor Statistics has documented that only 16% of the Latino community can work from home. They cannot socially distance. Why is that? Because they're working in the food industry, they're working in fast food restaurants, they're working in supermarkets, they're also in housekeeping, janitorial services. It is very difficult to socially distance in those spaces. And let's not forget that we are in a society that may not completely adapt wearing masks. And if we have, we may not be wearing them correctly enough to protect one another. So obviously these individuals are dramatically impacted. Next slide. So what have we done in our two clinics? Well, I'll share a few things, and I know Laguna Beach Community Clinic did something very similar. So we'll go through these fairly quickly. Next slide. So we had to respond. In the heart of Santa Ana, we set up a drive-through testing site. Our positivity rate peaked December 28th at 58%. Yes, you heard me correct, 58%. That is dramatically high. So yes, we're seeing cases drop throughout the county, but I'm going to tell you an unfortunate fact. It is still elevated in these hot zones in these cities. It is coming down, but it's not coming down fast enough. So we have to respond, and we did that also by really converting quickly to ensure that we could still provide care. We did it virtually. We made sure we had material to start educating our patients in a very sensitive manner of what is COVID, how they could get sick. We used various technologies to ensure that we could navigate their care. We have a pharmacy in our clinic, just like you all do in Laguna Beach, and we decided to start mail ordering their medications. We didn't want our patients to walk into the clinic if they didn't have to. So we spent the money to do that. Next slide. The other thing we did is if you did have to come in to be seen, we told you to wait in your car. We either send them text messages, gave them a pager system until they were ready to come in and walk into that clinical exam room. We did not have them walk in the door. We wanted to keep them safe. Another really, really important thing that we did, we've heard about, the pandemic, and some of you may have heard this terminology of the second pandemic. That second pandemic is the mental health pandemic that's been hurting us all. And so what we did was we actively started reaching out to all of our patients who have known diagnoses of anxiety and depression and ensured that they were connected with our counselors and our psychologists to ensure that they were doing okay. And trust me, some of them unfortunately were not. And so we wanted to make sure that we continued to be able to reach them even though they were uncomfortable coming in. Of course, we were absolutely dedicated to ensure that people still had the right access to other resources like food. And believe it or not, we did virtual dentistry. We provided dental care via Zoom and other modalities. Next slide. So now where are we? We are in this situation of great opportunity for the pandemic, but yet there's a lot of education that still needs to happen. We are vaccinating our communities as best as we can, but the challenges that we are faced with is very unique. Unfortunately, various studies, including some done by UCI and UCI Health, have found that the biggest hesitancy of vaccination is amongst our Latino community. And so we really need to do a grassroots effort to educate, empower them to understand it's important and also safe to get these vaccines. And it really lends an opportunity, hopefully, to start really turning the tide in these two specific cities. Next slide. So I thank you so much for your time. I'm happy to take questions when we're ready.
Thank you, Dr. Mayorga, for another great presentation and a different perspective on the pandemic. You mentioned something vital in your presentation, the second pandemic, or the twin pandemic, which leads me directly to our next speaker, Marshall McCreep, who again is the Executive Director of OC Mind, and we'll talk about the mental health and how the pandemic is affecting that tremendously.
Hi, everybody, and thanks, Dr. Bois and all of the speakers for being a part of this thing. I just want to acknowledge really briefly the phenomenal amount of work that everybody on this panel and everybody in healthcare is doing. And I do want to take one quick second to acknowledge my older brother, much older brother, Clayton Chow, who I have the privilege of knowing really, really closely. And so I have insight into what he's been doing. And all of us are taking care of the community. But the moment that the pandemic hit, Clayton took the opportunity to take responsibility for all 3.2 million of us. And I'm grateful to you, Dr. Chow, and everything you're doing, and wish you well. So thanks for giving me a chance to talk about mental health. You can kick the slides forward. I think the thing to know about mental health is that before COVID hit us, these things were pandemics or epidemics rather, in their own right. So depression, addiction, suicide, and homelessness were all considered individually at epidemic levels before COVID hit. And as COVID came along, it sort of poured gas on the fire of these epidemics and has worsened things. So we were facing a challenge, and we've got a bigger one to tackle, no doubt. Go ahead and advance the slides. There's 2 slides here that are just quotes, and I don't have to read them. You can read them on the screen. But essentially, what these 2 quotes are saying is that the mental health impact is going to be significant. We don't yet know the full extent of it, but some people are expecting that it will be higher in mortality than COVID itself, that severe. Next slide. And I think this is the most impactful for me, and we're hearing from this from world public health leaders, national public health leaders, state and local, that if there were ever a time where we needed to invest in the infrastructure that supports mental health, now's that time. So next slide. So we've been doing that at Be Well Orange County for some time, and we're just starting to get our legs under us. Another call out to Dr. Chow. I won't let his head get too big here, but he could also be giving this presentation. He was at the ground floor of the development of all of this. And essentially what Be Well is trying to do is take the fragmentation of our system, represented on the left-hand side, and put it through some coherent structure that organizes the community right there in the middle, so that on the other end of it, we can create a community-wide network of care that wraps a hug around our community, regardless of people's insurance or the clinical severity of their need, and get them their needs met, mental health, addiction, homelessness, and the like. So that's what Be Well Orange County is up to. Next slide. I'll give you just a little sense of things. And so 20% of people at any given time have a mental health disorder. That certainly fits with California. And those numbers in orange indicate when you look at some of our chronic conditions that are really known to be problematic for our communities, mental health is in multiples of those challenges. But it's often underrepresented in the time, attention, and funding that we give to those issues. Next slide. So not enough beds. A community needs about 50 beds per 100,000. In Orange County in 2020, we have 15 beds. So I've worked in the hospitals for almost the last 20 years. And so those are my friends and family, and they're working their tails off right now tirelessly in response to COVID. And we've already heard in this presentation, the demand on hospital beds has been excruciating. And in mental health, that's the reality all the time. All the time, there's a tsunami of need and there's not enough beds. And so we're working to create some of those beds. Next slide. There haven't been enough providers either. And so right now, we're meeting about 80% of the need with respect to psychiatry linked with demand. And as time moves forward, that need is going to increase and our ability to meet it is going to decrease. And so the point of this slide is, and the point of the slide about the beds is that we don't have enough licensed providers. We don't have enough beds. We're not going to meet the needs on the backs of licensed clinicians or hospital beds. We're going to need to do this as a whole community, united to create an integrated system. Next slide. Access is poor. I'll go quickly through this. The dark blue is just that of people that were asked what the mental health system is like, 54% that never sought treatment. From what they understood, the system is difficult to access. On the light blue side of people that actually did go out and try to find treatment, 66% said, yeah, it's really tough to access care. Next slide. So the impact of this is that people delay care and end up seeking care in high cost, poor outcome environments like emergency departments. Next slide. So as a person who's spent a lot of time in Orange County hospitals, this is our scorecard, or one proxy measure of the system that we need to develop. So every year there's 50,000 admits in Orange County emergency departments for mental health and addiction. On average, and on the low end, I would propose to you, each of those admits is $2,000. So we spend about $100 million a year pre-COVID on poor care with poor outcomes, wrong time in the wrong place. At least 70% of that is avoidable. So what Be Well is trying to do in unifying the community is to create the system infrastructure that can start to address these things, that can start to increase access and build out an infrastructure that actually is coherent and accessible. COVID has just underscored the need to do that, and the need to do that with a sense of urgency. So that's what we're up to. Next slide. There's three primary areas of our focus, and this Clayton and I did together some time ago. We need to create a navigation and crisis response system. We need to build comprehensive care campuses for mental health and addiction that are available to everyone, regardless of their payer status. And we need to build out that network of providers, expanding the definition of what constitutes a provider. Because as we saw, we're not going to have enough psychiatry or licensed clinicians if we're going to meet the need. So I'm going to focus just on the regional campuses for a quick minute, and then close out and be available for questions along with everyone else. Go ahead and click the slide forward. Oh, go ahead. So our North Campus, one more. So, and just go ahead and click all those open. I didn't realize I had it on animation. So this is a picture of the facility that we just finished as a unified community in the city of Orange. So the entities that did this together is the County of Orange, Medi-Cal, Cal Optima, our health plan, and 5 of our not-for-profit hospitals just completed this new care campus in the city of Orange. It's the first of at least 3. And this is the first in our county and the state where we have integrated mental health and substance use across a whole continuum and available for the community regardless of their payer status. I won't necessarily list off, all of those services, but essentially those are urgent care services to long-term residential services, both substance use and mental health, all co-located in the same place. And we're working now on our next campus, which will be located in the city of Irvine, and then a third to be determined. And we're also working on the navigation system, some mobile crisis response capability, and increasing access with increased providers. So appreciate the opportunity to share this with you all. COVID has certainly exacerbated the need, and there's no time like now to rally the community and build out this system in a way that's accessible to our community. So thanks, Dr. Rubal. I'll stop there.
Thank you, Marshall, for again sharing that wealth of information. I want to thank all the keynote speaker as well as all our panelists for the phenomenal information that was shared. We ran over a little bit, but we still do have some time for questions for those of you in the audience that would like to ask something of our panelists. If you look down at the bottom of the Zoom, there is a function where you can raise your hand. So if you have a question, go ahead and hit that, and then you'll be placed in the queue. Once you come up, I will quickly let you know that you will be unmuted. You can keep your respectful questions short and brief, and this will allow us to get through as many questions as possible. So with that, let's see here. Our first question would be Randy. Well, Randy, are you there?
Hey, Dr. Rubal. Yeah, it's good to see you out here. The symposium is phenomenal, really. My care is I have idiopathic pulmonary fibrosis, and what is the response? You guys that are the experts for me, I've been at Cedar Sinai waiting on a lung transplant, but still I've heard nothing on treating patients with pulmonary diseases, and I'll end it there.
Yep, I'm happy to attempt to answer that question. I'm not sure if anybody else is up for it. I'm happy to hand it over. Okay. Really important question. People with chronic lung diseases were not specifically not specifically excluded from the clinical trials, but those with very severe disease, I do believe they had an exclusion, specifically for immunocompromised individuals, which your condition may or may not include. But for the most part, COPD and chronic lung disease at large were not included. What we have been doing at UC Irvine, I will tell you, we thought really hard about this question. Are we going to extend when people have comorbid conditions? Are we going to extend to people with chronic lung disease or chronic immunosuppression? And what we've come out with is that we will do it on a case-by-case basis. Physicians know the nuances of each individual's risk profile best. So depending on the medications that you might be on, and depending on your inherent lung condition puts you at higher risk for severe disease should you get COVID. That's, I think, clear to anybody, whether you have a medical degree or not. The real question is, will you be able to mount a sufficient response? Do you have any other contraindications to the vaccine, particularly allergies? And I'll stop there and let my colleagues weigh in.
This is Clayton. So I can tell you that for folks who have severe condition like Randy, what we have done is relying on a large health system with specialists to help us make decision on whether or not to vaccinate. Clearly, the state currently is in the midst of making decision for vaccination based on the age framework. And I believe that there's some consideration to pay prioritization to individuals 75 years and older, and then for individuals who's 65 to 74 with chronic health condition, based on the CDC list of what chronic health condition that would put people at risk, as Dr. Godey just mentioned, and then 65 to 74 without health condition. So I do know that the state is moving towards making that type of prioritization.
Thank you, Dr. Cow. Thank you, Dr. Gohill. Next, we'll take a question from Kay.
Hello, can you hear me? So here's the thing that I have a question around, and I'm a longtime Laguna Beach parent. We have so many parents that are anti-vaxxers. How do I, as a person who, am an influencer and doing all kinds of things with the schools, try to change that?
So let me take a stab at answering that question. So thank you. That is a very important question. We at the county have been working closely with Orange County Department of Education as well as with the school district in developing educational material geared towards children regarding the COVID vaccine in particular. I think we are finalizing the curriculum, and we are looking forward to sharing that with the kids. We will also engage with a communication firm to develop targeted information. We have gotten some very strong support from our Orange County Catholic Diocese. I can tell you that I have, if you follow the news, I was threatened by the anti-vaxxer and anti-mask folks, and that has picked up. And the unfortunate thing is that now they are also threatening our app developer. You probably heard about Othina in the community. We developed an app to support the process of not only testing, but also vaccinations. And unfortunately, the app developers now gotten threatened as well. So it is a big concern. And so we would need to have a community-wide education to support people to make the right decision.
And I'll just add a few things. I mean, I think this is a very challenging time, especially as Dr. Gohill mentioned earlier, regarding the vaccine. There is a lot of concern about how quickly this vaccine came to market. And I think the anti-vaxxer movement has really jumped on that. But I think as we're here speaking and understanding simply the science behind it, we understand why it was called Operation Warp Speed. We understand how it came to market so fast. And what I continue to stress to our population, and more importantly, speaking to them in Spanish about it, is really understanding what that really meant. What it really meant was this was a monumental moment in our time where you had the scientific community rallying around something that was absolutely imperative for the entire humanity. At the same time, the financial backing to move forward on two really critical elements. And that was recruitments for the study and mass production, because we've been studying coronaviruses for decades. We understand it. This is something that scientists have been studying for a long time. Now, we've also understood mRNA vaccines for a long time as well. This isn't the first mRNA vaccine. It's been seen and studied in Zika, as well as rabies, and even in some flu vaccines. So it's really important to share that information with folks, because that gets overlooked at times. And so again, at the end of the day, this was a all in, all out effort to try to combat this pandemic. We are way ahead of everything else we've ever done before. Why? Because we want people to stop dying. That's really the bottom line.
And if I may, there's rumors around how these vaccines have been produced and get approved. Every single important step was not skipped. Let me repeat that. Every single important step in bringing the vaccine to the community has not been skipped. So all the manufacturers followed the protocol. And as you all know, the US FDA is the toughest entity in the world in approving and authorizing medical products for use, right? And so none of the important step has been skipped at all. So that's a very important point.
Next, we'll take a question from actually Dr. Thomas Bent.
Okay, can you hear me now? Thank you. Hello, Jose. Great to see you tonight. Before I get into my question to this distinguished panel, I would like to respond to Kay Matee, who asked a critical question about vaccine hesitancy. Kay, we got to make vaccines cool for everybody. The California Academy of Family Physicians has an initiative to use social media as an outreach to our colleagues and our patients to get vaccine information and acceptance out there. I am personally targeting young people who are charismatic and engaged with social media who come to my office, and I am enlisting them as my agent. Nobody wants to hear about some senior citizen saying you ought to do this, but from a 25-year-old peer, it's working. To learn more, okay, go to familydocs.org, which is my association's website. Now to my real question. Thank you for that opportunity. I'm Tom Ben. I'm a family doctor. I am past director of Laguna Beach Community Clinic, past director of UCI Family Health Center. Yes, I had your job, Jose, and we don't need to go through the rest of it. So I've lived in the FQHC and the community clinic world for many years. The FQHCs, as Jose articulately pointed out, are the primary source of care for our most vulnerable populations, the underserved, the homeless, the crazy homeless, and of course the Latinx population that it is so dear to my personal heart. So those people who need the vaccine most are going to get it at our clinics, but they can't because we have an empty refrigerator. What efforts are being made to increase vaccine deliveries to these very critical health centers? Thank you.
If I answer that question, people would have doubt. I would refer to Dr. Rubal and Dr. Mayorga to answer that question based on our current or recent conversation with the Community Clinic Coalition.
You're on mute. I want Dr. Rubal to answer this question because I think it's great news. Dr. Rubal, we can't hear you.
Can you hear me now? Yeah. So there's been a lot of change this past week, and I'm very proud to say that the community clinics have banded together to form a large distribution for vaccinating those vulnerable communities that we've been discussing. So over the next week, the vaccine delivery to those communities is going to ramp up significantly. And that's been through the support to Dr. Chow's credit, who has advocated for us at the county level. And so I'm very, very excited, very proud to say that between all the community clinics, if I can go ahead and say this, Dr. Chow, we are scheduled to start receiving approximately 15,000 vaccines a week between all the community health centers to start vaccinating those communities which you spoke of, which I think, if I can really quick, just speaks to how vital these community clinics are, and they're part of the solution of what needs to be done.
Thank you, and
I don't know if you want.
I would add, Dr. Ben, thank you for bringing that point up. On top of the community clinic, the county now are using what we call the social progress index, which we brought into the county, looking at the social determinant of health inequity in hotspot in Orange County, particularly the lower SES area in Orange County, as we are overlaying the percentage of COVID positivity rate in those community, and we will target those hotspot, those neighborhoods that perhaps had not been receiving care at the community clinic, because we do know that there are pockets of population because of transportation or what have you. And so we are bringing a mobile vaccine pod directly to those identified neighborhoods.
Next, we have Sue Stewart.
My
Sue,
question,
are you there?
yes, my question is, what is the panel's opinion about double masking?
Dr. Gohill just had a huge conversation, not putting you on the spot. But...
Well, I'm gonna let Clayton take first dibs on it, because as a Orange County, I'm not sure if there's any directive that's headed down the pike, and then I'll share my opinion.
Sure. Currently, there's conversation at the state level as it related to the instructions for our mask mandate, whether or not people should double mask. And clearly, this last few days, there's been conversation everywhere. You turn on the media, speaks to, do you need to have a certain type of mask on top of your cloth mask that we have been encouraged people to wear due to the N95 shortage in the country, not just particularly California. And so from a public health perspective, we have not made a decision yet. There's conversation at the state level at this point. Dr. Godhair?
Great. You know, it's really hard. I should back up and let you know what my background is. So I'm an infectious disease physician, so trained in infectious disease, see patients with infections. Okay. The other part of what I do is to help direct the COVID response, but all infection prevention type of activity at the hospital. That includes influenza, tuberculosis, what have you, anything that can get transferred between patients and human beings. And so people in my world, the world of healthcare epidemiology and infection prevention, have been thinking about the details and technology associated with masking for a very long time, predating COVID. And we have really come down, at least within our circles, about masking, the idea that we have manufacturer grade masks, like surgical masks, N95 masks, available and tested by a manufacturer for both breathability, for its ability to minimize CO2 buildup, and then balance that with infectious disease acquisition risk. Those three things have to be all in balance. And to national level standards, state level standards through Cal OSHA and other bodies. And taking the decades worth of work that has been put into that from people in my business, we understand fully that a single mask is sufficient. You know, in the world of healthcare, for example, where the greatest risk lies, where you are seeing patients with active infectious diseases, a single mask is deemed to be sufficient. So, you know, it's troubling for people in my world to think about the multiple different ways in which you can interpret risk. You know, if the idea is where do as much as you can to prevent acquisition. When you focus too much on any one thing, so if it's a mask or the bunny suits that people may want to wear to protect themselves, then you lose attention on other really critical things like social distancing, hand washing, and the mask. So keep it simple, do it right, do it consistently every single time. And I really believe that if people wear a mask, we have good data now, not many trials being done, but at least two good pieces of studies that showed that community masks, single, at that time they weren't thinking about doubles, community cloth masks are very effective in preventing acquisition. So I would say if you have been COVID-free, using your single mask this whole time and doing your hand hygiene and social distancing, you've probably done a pretty darn good job, and keep it up.
And I would echo that, and I think it was Dr. Mayorga who earlier made the point that we still do have people in the community who are not wearing the mask correctly, and we really need to focus on that point, right? Rather than having this community hysteria, oh, now I got to do double mask. Well, it won't help if you're still wearing the mask incorrectly. So that's the point of education that we must continue to do.
Yeah, and I'll just make one final comment. Dr. Gohel has done a really good job of ingraining in my mind not to touch my face and not to adjust my mask. Guess what's going to happen when you have two on? You're going to play more with your face, and you're going to give yourself COVID, period.
Okay. The next question, I'm proud to say and very honored to say it's Isabel Becerra, who is actually, if I can introduce her really quickly, is the Executive Director of the Coalition of Community Health Centers of Orange County, and has been a major advocate for not only Laguna Beach Community Clinic, but all the FQHCs. And so, Isabel?
Hi, thank you. Can you hear me?
Yes.
Great, thank you. Thank you so much for putting this wonderful symposium on to talk about, of course, you know, the the topic of the year. And I love the way that the whole data has been presented, all the facts and figures. I was really happy to hear Dr. Bent on the phone. Hi, Dr. Bent, if you're still on. I wanted to answer specifically your question that we have been tirelessly working with the healthcare agency, with CalOptima, to try and again highlight that the hardest hit communities of our county should be prioritized in receiving the vaccines, should be again, a major area of focus given the disproportionate impact that it's had on our communities. And I wanted to also publicly acknowledge Dr. Chow for stepping into the limelight and their fight with us, because we did get together, we formed 5 super hubs with spokes, and the spokes are all the geographically located health centers throughout our county. If you look at our county, the community health centers are placed and opened up for business, if you will, where the communities need us the most, aligned with the social determinants of health that we all know impact greatly the access to healthcare for our communities. And therefore, because we're geographically located, because we are all, patient-centered medical homes, all of our providers are board certified, double board certified in various cases, we have the capacity and infrastructure to provide those vaccines to those most in need, and of course, following state guidelines. And again, with the infrastructure in place at the healthcare agency, we were able to secure the volume that we anticipate that we can provide on a weekly basis to help spread or increase the number of vaccinations that our community gets. So I wanted to just highlight that. I know we have 2 wonderful community health centers here being represented, but of course they're all over the county, right? There's 25 entities operating 80 locations who collectively care for over 400,000 patients. And I just wanted to stress that for both the panel, but also for all of you that are listening in and wondering how we're going to be able to do that. Well, we have the infrastructure in place to do it. Thank you.
You unmute, Dr. Rubal.
I keep muting myself, so I apologize. I just want to be respectful of everybody's time. I know we went a little bit over, but I really want to thank Dr. Gohill, Dr. Mayorga, Dr. Chow, Marshall for giving of your time, especially how you guys are being pulled and already giving so much to the community on the front lines. Thank you again for sharing this wonderful information to our audience. And again, hopefully we can continue to discuss this amongst our friends, our families, our neighbors, and continue to move forward as we hopefully get over this pandemic soon. So I want to thank everyone again. For those of you who would like to share this afterwards, we'll have this video online for those of you who would like to share it with friends and family. So thank you all once again.